Welcome to this MedNexus Explainer. Today, we're exploring a hidden, slow-moving power right inside the human body. Our immune system is usually celebrated for its lightning-fast response to threats, fighting off invaders in literally minutes or hours. But what happens when that exact same protective force decides to bide its time, when it gathers strength in the shadows, only to unleash a devastating strike days later? Well, that's the fascinating and honestly sometimes destructive world of type 4 hypersensitivity. Think about this for a second. You brush up against a plant in the woods, or maybe you put on a simple nickel watch. For a day or two, absolutely nothing happens. You think you're totally in the clear. But then, an intense, blistering rash erupts out of nowhere. Or think about the classic tuberculosis skin test, or even the really devastating reality of a host body rejecting a transplanted organ. So what actually connects all these completely different events? They're all triggered by this slow but incredibly formidable immune response. So the absolutely crucial point to understand here is that type 4 hypersensitivity is a total outlier among the hypersensitivity reactions. If you're familiar with types I, 2, and 3, you know that antibodies are usually the stars of the show, right? But here, the antibodies completely step aside. This is a purely T-cell-mediated immune reaction. It relies heavily on T lymphocytes, macrophages, and chemical messengers called cytokines to do the actual tissue damage. Basically, it's cellular immunity, but acting on a serious delay. Here's our roadmap for today's explainer. We're going to cover 1. The delayed threat. 2. Cellular mechanisms. 3. The clinical battlefield. 4. Detection and management. 5. Contrasting type 1 versus type 4. And finally, number 6, the high-yield exam points you definitely need to know.
Starting with Section 1, the delayed threat. Because when it comes to type IV, timing really is everything.
This whole phenomenon earns the name delayed type hypersensitivity, precisely because of its distinct timeline. When your body is initially exposed to the trigger, the antigen, there's absolutely zero immediate clinical symptom, nothing. Instead, the reaction just quietly develops in the background, usually hitting its peak between 24 and 72 hours later. The immune system is essentially taking a couple of days to mobilize an entire army rather than just firing off a quick warning shot.
Moving into Section 2, cellular mechanisms. Let's zoom in and look at the microscopic chain reaction that's happening during those critical 24 to 72 hours.
Okay, so it all kicks off with antigen presentation. Specialized cells process the incoming antigen, and they hand off that threat to our body's defense commanders, the T cells. Specifically, we're talking about the CD4-positive helper T cells and the CD8-positive cytotoxic T cells. Once these guys are activated, they unleash a massive chemical storm, pumping out cytokines like interferon gamma, tumor necrosis factor, and interleukins. And it's exactly this cytokine storm that sets the stage for the actual tissue injury.
Think of those cytokines as a blaring distress beacon calling in the heavy hitters. The T cells use them to recruit and activate macrophages. So while the T cells are the ones giving the orders from the top, the activated macrophages are the foot soldiers on the front lines. They're the ones driving that intense inflammation and causing the actual microscopic tissue destruction.
But what happens when the threat just won't go away? Sometimes the immune system simply cannot clear the antigen. And when that antigen is persistent, it leads to chronic T-cell activation. So what's the body's backup plan? Well, if it can't kill the invader, it tries to build a prison right around it. This is exactly how a granuloma forms. It's a specialized microscopic wall of immune cells trying to quarantine that persistent threat.
All right, Section 3, the clinical battlefield. Let's see how these invisible cellular battles actually show up as real-world diseases in patients.
And this brilliantly illustrates the connection between cellular theory and everyday clinical practice. One of the absolute most common type 4 reactions is contact dermatitis. You know those incredibly itchy red vesicles you get from poison ivy, a latex allergy, or even just cheap nickel jewelry? That is exactly your T cells and macrophages at work. Similarly, we rely on this exact same mechanism to test for tuberculosis exposure. With the Montus test, we inject a tiny bit of TB antigen right under the skin and then just wait 48 to 72 hours. If a hard, raised bump and induration forms, it means your T cells remember that antigen and are actively attacking it.
But we have to remember, type 4 hypersensitivity isn't just about an itchy rash or a diagnostic skin test. It's actually responsible for some severe systemic threats. Those granulomas we just talked about, they're the classic hallmark of diseases like tuberculosis and sarcoidosis. Plus, this exact same cellular mechanism is the driving force behind devastating autoimmune conditions. In type 1 diabetes, these T cells get confused and destroy the insulin-producing beta cells in the pancreas. In multiple sclerosis, they actively attack the protective myelin sheath in the central nervous system. And crucially, if a patient gets a transplanted organ, it's primarily these T cells that recognize that new tissue as foreign, which leads to graft rejection.
Now, while we focused a lot on macrophages causing collateral damage, we really need to briefly spotlight the direct, lethal capabilities of those CD8-positive cytotoxic T cells. These guys are basically cellular assassins. They don't just sit back and rely on inflammation. They can physically bind directly to target cells, like the ones in a transplanted organ, release a protein called perforin to quite literally punch holes in the cell membrane and force that target cell into apoptosis, or programmed cell death. It's brutal, but highly effective.
On to Section 4, Detection and Management. So how do clinicians actually identify and treat this hidden assassin in the real world? Making the diagnosis relies heavily on a really solid clinical history. You have to connect the timing of an exposure to those delayed symptoms. Clinicians will use patch testing for dermatitis and, of course, the Mantoux test for TB. But if a tissue biopsy is taken, there is a very classic histological signature you'll see under the microscope. You're going to spot a heavy presence of mononuclear infiltrates, meaning lots of macrophages, T cells, and sometimes even fused giant cells, but noticeably fewer neutrophils compared to what you'd see in a rapid acute bacterial infection.
When we look at treatment, the core strategy across the board is essentially to suppress the very immune system that's overreacting. The absolute simplest method is trigger avoidance. Just don't wear the nickel watch. But for more severe or systemic reactions, clinicians have to rely on corticosteroids to rapidly cool down that inflammation, or use powerful immunosuppressants like tacrolimus, cyclosporin, or modern biologics. And obviously, in specific cases like TB or MS, targeted, disease-specific therapies are absolutely required.
Section 5. Type I versus Type 4. This is a critical contrast you need for building a rock-solid immunological foundation.
Now, what's really interesting about this slide is how contrasting these two reactions reveals a perfect dichotomy. Type I is that explosive, immediate allergy most people immediately think of, like a peanut allergy or a bee sting. It's mediated by IgE antibodies, it happens almost instantly, mast cells dump histamine, and it can quickly lead to fatal anaphylaxis. By contrast, Type 4 is the exact opposite. It's purely T-cell mediated, it's delayed by several days, relies on macrophages and cytokines, and results in conditions like contact dermatitis. Grasping this dichotomy is absolutely key for your exams and clinical practice.
And finally, Section 6, High-Yield Exam Points. Let's do a rapid review checklist for everyone prepping for exams.
All right, here's your rapid review checklist. Remember this. Type IV is purely T-cell mediated. The reaction is naturally delayed, taking a full 24 to 72 hours to peak. Central antibodies, they are not involved here. Your classic textbook examples are contact dermatitis and the Mantoux skin test. Also remember that chronic activation leads to macrophage-driven granulomas, and those CD8-positive T cells are totally capable of direct target cell killing. Cement these concepts in your mind, and you will totally master the core of this pathology. And hey, if you ever find yourself totally blanking on an exam or just trying to pull this from memory later on, here's a fantastic, punchy memory trick. Type IV. Just say to yourself, an IV takes time to act. It's not an instant injection, right? An IV drip is slow and delayed. Let that simple mental image anchor the concept of that 24 to 72-hour delay permanently in your mind. To wrap up, we're going to leave you with this concluding thought from our source material. Type IV hypersensitivity brilliantly demonstrates the immense double-edged power of our cellular immunity. While our T cells are absolutely essential for protecting us against deep-seated infections, this explainer shows how that exact same protective machinery, when misdirected or overly aggressive, becomes the very thing that destroys our own tissues. It's an incredibly delicate, fascinating balance between protection and destruction. Which leaves us with a pretty profound question. If our most powerful cellular defense is also capable of becoming our most patient destroyer, how close are we to perfectly reprogramming this army to cure autoimmune diseases without leaving ourselves entirely defenseless? Thanks for joining us for this MedNexus explainer, and keep questioning the science.